Hi, everyone. It's great to be here today. So what we're going to discuss in this presentation is very relevant to what Dr. Wang has discussed so far about how can we design responsible and trustworthy AI technologies specifically for supporting mental health. And ambulatory monitoring has brought really a revolution in mental health, since it allows us to collect data from people in their real lives beyond what we can do in traditional clinical settings. Coupling ambulatory monitoring with machine learning brings us the opportunity to recognize complex patterns in data samples, to identify subtle changes in behavior, and to have early prediction of relapses in a personalized manner. There is a lot of evidence out there on how we can support mental health using machine learning and data analytics. For example, in this recent study of an aggregated review of 28 papers, we have evidence that we can predict and classify mental health conditions such as depression, sometimes even better than what we can do in current observational practices. However, there are a lot of challenges that are associated with this endeavor. And first of all, there are a lot of computational challenges, such as the inherent inter-individual variability, the sparsity of labels, especially when it comes to mental health and ambulatory monitoring. Many times we rely on a single label that is given by the participants within 24 hours, and also the variable base rate of focal behaviors. Therefore, there has been a lot of literature recently, including work coming out from our lab, on how to design machine learning methods that are personalized or group-specific or generalizable across different populations. However, lately, beyond the technical challenges, our society really faces a lot of societal challenges in how we can adopt these technologies in a responsible manner. And in a recent survey by the Pew Research Foundation, experts really emphasize the need to responsibly design and adopt these technologies. This is also evidenced by recent legislatory efforts, such as the one that we have from the European Union coming, the AI Act, as well as here in the US, the FDA has proposed this regulatory framework for addressing core issues related to data governance, accountability, and transparency. And recently, we have all these conversational agents and large language models that have really now exacerbated these concerns. In this study, what the authors have found were that chatbot responses were rated of significantly higher quality and more empathetic compared to clinician responses when patients have actually asked them for advice. So what we're trying to do in our research is to address fundamental algorithmic challenges for achieving responsible AI and trustworthy human-AI partnership in the context specifically of tracking human behavior and mental health. So in terms of privacy, we are investigating the leaking of personally identifiable information and ways to mitigate this leaking from the data. In terms of fairness, since privacy and fairness really go hand in hand, we are trying to deconstruct sociodemographic biases in the data and find ways in order to achieve more equitable mental health, more equitable AI applications for mental health. And finally, we're trying to see how can we design explainable AI models using domain knowledge in order to bring in these AI technologies closer to the clinician and enhance the transparency and explainability of these AI technologies. Let's start with our work on privacy mitigation. So first of all, the main axis of this work is to investigate how personally identifiable information is present in multimodal data that are commonly used for ambulatory monitoring in mental health, and also to what extent feature transformation and feature selection techniques can mitigate some of these privacy concerns. We have exemplified this in a study that was conducted a few years ago, and this data comes from around 200 participants, and these are hospital workers and nurses that were collected from 10 weeks. The purpose of the study was to collect well-being measures of hospital workers, such as anxiety and affect. And we have used wearable devices and smartphones to conduct this. So in this first task here, what we try to do is to characterize user re-identification risk from 69 sensor-based features that include physiology, daily activity, and acoustic measures. And the way we thought about actually quantifying this re-identification risk was to train a classifier using these 69 sensor features and identify to what extent this classifier can classify among these 212 participants. So classification accuracies, user classification accuracies in this case ranged between 81 and 93%. And also in this graph here, you can see how participants' data were clustered, and the color coding is the participant ID. So essentially, we can see that there is a lot of evidence of participant ID that is actually present in the data. We wanted to see how this can be extended beyond user identification to other constructs such as biological sex and income. And we also saw similar trends here. For example, we saw that essentially, when we use the same data to classify biological sex, we get accuracies up to almost 95%, and the same for income. Now, we also wanted to see to what extent we can use feature transformation and feature selection techniques in the way that we can reduce evidence of this personally identifiable information, but at the same time preserve utility outcomes that are related to mental health. And one very common utility outcome that we are examining here is anxiety. So essentially, what we see here, first of all, the first part of these graphs is the classification accuracy of anxiety based on the same measures after we have conducted the feature transformation or feature selection techniques. And the second set of bars is the classification accuracy on the personally identifiable information. So what we see from this graph is that when we conduct feature transformation and feature selection, we are able to some extent preserve the utility outcome of anxiety, but at the same time reduce some of the evidence of this personally identifiable information without achieving, of course, a reduction closer to zero. Beyond the measure level, beyond the feature level, we wanted to see to what extent evidence of personally identifiable information is inherent in the actual signal. And for this reason, we also chose the speech signal, because the speech signal really has rich spectrotemporal variations and is indicative of many sociodemographic quantities. So we designed a speech anonymization algorithm that relies on adversarial learning. And as part of this speech anonymization algorithm, we wanted to preserve mental health information. In this case, we worked on depression, but at the same time, reduce evidence of speaker identity. So essentially, our adversarial learning framework was designed according to this purpose, but we also wanted to pay attention closely to preserve the content of speech and the language content. So for this reason, we actually added some constraints that preserve the language content from from phonetic posterograms of speech. And we tested this in the depression dataset, in a publicly available depression dataset. So what we saw here was, first of all, our proposed anonymization method can still preserve a predictive accuracy of depression similar to the original speech signal. We also saw that our proposed anonymization method can, to some extent, reduce evidence of speaker identity in the signal. But at the same time, this also yields increased word error rates. And this is also corroborated by results from perceptual experiments in which users actually report less naturalness when they listen to the anonymized speech signals. So while this adversarial learning method is a decent preliminary approach in order to solve this problem, we recognize that there might be other approaches out there, such as approaches that might rely on generative AI and generative learning that can yield better results. Now, moving on to the second thread of our research about fairness. What we wanted to do here, first of all, is that, as it was very well said in the previous talk and in the discussions, fairness is not so only a technical thing, but fairness needs to be discussed with experts and with the society as a whole. So first of all, with our collaborators from psychology, we wanted to write this conceptual paper on how to think about fairness. And what we try to acknowledge here is that identifying bias in this machine learning pipeline is not only inherent in the data and in the model building strategies, but also in the way the model is designed, in the way the problem is formulated, and in the people that actually build and think about the model. And also, when we are to mitigate bias, mitigating bias is not only a one-time thing, but it has to be examined iteratively in multiple phases, not only in the model design, training, but also in the way the model is being deployed in the society and to the people that it actually serves. So moving forward from that, we also tried to do an evidence-based study on how bias is embedded in data. And specifically, we looked at speech again because of the information that speech has, but also because speech is very much related to sociodemographic characteristics. We know that there are differences in anatomical structure that are reflected in the vocal tract and in the vocal folds between different sociodemographic groups. But there are also differences that might be embedded in speech because of the societal expectations, because of the gender knowledge and the cultural norms. So essentially here, we wanted to first examine acoustic differences among sociodemographic groups as a potential source of algorithmic bias. We second wanted to underscore the importance that it might not only be important to have the same prediction rates for all sociodemographic groups, but it might be also important to preserve meaningful differences among sociodemographic groups that can potentially allow us to design better treatments. And finally, we would also like to explore the effectiveness of debiasing methods in the domain of mental health analytics. In this case, we have worked only on gender bias, but we have results in another context with race and ethnicity bias, and I would be happy to discuss more about this. So here, in order to examine acoustic feature dependencies among female and male speakers, here are the 20 most discriminative features of depression in this left side here, and then in the right side here, we have the 20 most discriminative features of gender. And we see a lot of overlap between the two, which indicates that whatever we use for depression can be actually used in order to predict gender. In a second note here, in our data, we saw significant differences between male and female speakers in terms of diagnosed anxiety, which corroborates with what we know from the clinical settings. However, when we use machine learning algorithms based on speech features in order to train models and detect depression, these differences are not really preserved in the actual machine learning outcomes, which means that potentially these machine learning models cannot preserve, in the way they are right now, cannot preserve meaningful clinical differences that might be important to the clinician. Finally, we wanted to see debiasing methods. And on how debiasing methods can help us potentially address some of these challenges. Results that we got from here was that feature transformation via adversarial learning usually tends to help. Preserving a small number of features that might be indicative of the utility outcome further helps, not only in accuracies, but also in equality of opportunity rates. And also removing from the input model features that might be dependent of the gender information further helps in debiasing. Finally, I would like to discuss a recent research theme that we have been working on this interaction and joint decision-making between the human clinician and the explainable AI models. And this is a work that is currently being conducted by my PhD student, Ke-Xin Feng, who will be here presenting a poster in the afternoon session, and I would really encourage to go and see his poster. So we know that collaborations between humans and AI are now transcending more and more into relationships that are iterative and evolving. And potentially, explainable AI algorithms might be able to help augment human capabilities. But we are really not sure how to do this and what are these design and guiding principles on how to do this. In the way we're trying to approach the problem, we're trying to integrate domain knowledge in order to do that, and we're trying to integrate insights from previous findings in order to achieve this goal. So we are again working in this field of depression detection, specifically from speech, and we are relying on evidence that exists that there are these these anatomical differences differences in depression between healthy and patients with depression that are reflected in reduced vowel space, which means that patients with depression have a more reduced range between the first and second formal frequency that is not there in patients, in healthy people. So what we're trying to do is that we are trying to build explainable machine learning models that take speech at the vowel level. So at the vowel level, we're trying to model these spectrotemporal variations. And moving forward from the vowel level, we're trying to see how we can build high-level descriptors and model these temporal dependencies at the high level across speech segments. The algorithm that we have used for that achieves F1 score very equivalent to state-of-the-art methods. However, we're also trying to see how this algorithm would actually work in a clinical setting where a clinician would interact with the algorithm either for the purpose of diagnosing or even for the purpose of clinician training. So my student Kevin has built this interface. And as part of this interface, first of all, the clinician can listen to the original audio signal, can look at the transcripts. In addition to that, the clinician can track the decision of the AI algorithm in a way on how likely at each specific utterance the algorithm thinks that this might be a patient with depression. And it can also track the speech spectrogram at the vowel level in order to see more low-level spectrotemporal variations, as well as parts of the speech spectrogram that have been most useful to the algorithm in order to conduct its decision. We will be starting to recruit clinicians in the next few months, hopefully at the national level, in order to be able to do this. So essentially here, we wanted to summarize our findings. What we saw, first of all, was that multimodal features and speech, including speech, actually preserve dependencies in terms of personally identifiable information. Feature transformation and adversarial learning methods can actually be a decent solution for removing some of the evidence of this personally identifiable information. And also what we're trying to also argue here is that integrating expert knowledge would be important for potentially making these interfaces more trustworthy in explainable AI. Finally, what we would like to outline is that while it's great that we are start thinking about this, it would be nice to think about this in a collaborative manner and in a holistic framework involving not only clinicians, but also patients and communities. And it's also necessary to start thinking about how to give human-centered technologies more ethical principles, because this will come more and more in AI-based human decision-making. Thank you so much, and here are some of the pictures of the students who actually did this work.
Yeah, I really loved in the second to last section, there was a slide where you were essentially comparing the significant features for identifying that correlated with depression and even sex. Two questions.
Yeah.
One is, are there any of these features that you use for anonymization that essentially, have you looked at how they correlate to the language that the user speaks, or are you only considering English speaking?
That's a great point. We're only considering English speaker because the majority of data sets that we have are from native English speakers. However, there is definitely a dependence in the language because these features reflect essentially vocal tract patterns and patterns in the vocal folds. And we know that being a non-native English speaker, for example, or uttering a different type of, or having a different type of language has a dependence on these features. Yeah.
Sure. And then my other question is, I really like that you're considering all those features. I was going through thinking about how are you anonymizing everything? And then you're starting to use AI models to look at the actual spectrogram. Have you considered using sentiment analysis where you're actually processing the speech and the text and getting just a really simple, this is positive, this is negative, this is kind of neutral?
Yeah, so basically space sentiment analysis at the acoustic level relies on this spectrogram. So essentially, this is an inherent part of like the acoustic properties that are in the spectrogram can be used for sentiment analysis. And we can also try to do that just because affect is such an important part of depression. We can definitely try. We haven't considered that. We have really narrowed down on the speech spectrogram right now. But yeah, we would be happy to do that. And actually, from preliminary interviews that we had with clinicians, there was a lot of discussion from them about the linguistic part of the interview and all this very heavily linguistic content, but not so much about the acoustic content. Yeah.
Thank you.
Yeah.
Hi, thank you very much. Oh, right here. Thank you very much for the great presentation. Really impressive work, this presentation and as well as the one previous to it. So as a physician scientist, actually, so I hear the sort of the interaction with the physicians and all of that interesting space. And my mind goes to the patient physician as well, the interaction between them, so the clinical encounter, and that's where really this shared decision making comes into play. So I wonder, now I know a lot of these models are earlier in the whole era of AI in healthcare, but then when it comes to implementation and taking into account that interaction with the patient, especially from a trustworthiness perspective, not just to the trust of the physician, but also trust to the patient, which also plays to the trust to the physician. Are we there yet? Is there work in that space? Is there work planned in that space? Do you think there's potential there, or is it too early?
I think there's definitely a potential because all these speech technologies have really evolved the last years, and now we have all these SDK packages that actually can bring these technologies out there in real life, right? So we can get, not maybe real time, but we can get potentially some type of a post assessment of this clinical encounter, which can be very helpful potentially for the clinician. And I know there's a lot of work in the space of the clinician encounter in terms of how potentially bias from the clinician might actually be embedded in that encounter, and this is such an interesting space there. I don't think that the technology is there yet, but I think it's getting very close, and that would be really an interesting field.